Okay. Good afternoon, everybody. Thank for joining us today in our cardiovascular grand rounds. Welcome, Dr. Velazquez, and thank you for joining us today. And thank you, Mrs. Reese McLeod. My name is Lorena Telles. I work at the Cardiovascular Foundation, and it's my pleasure to introduce to you our moderators today. Dr. Maria Juliana Rodriguez, Chief of Cardiac Failure, and also Dr. Monica Lopez, cardiologist of the Cardiac Failure Unit. Welcome and thank you for moderating this event.
Buenas tardes a todos y muchas gracias a todos por su asistencia. Mi nombre es María Juliana Rodríguez. Hoy estaré compartiendo esta moderación con la doctora Mónica López. En este momento tenemos algunas dificultades técnicas logrando que se conecte, pero ya pronto estará ella con nosotros. Les recordamos a todos que al conectarse a esta conferencia están autorizando el tratamiento de sus datos personales, los cuales serán tratados de acuerdo a la Ley 1581 de 2012 y nuestra política de datos personales, la cual pueden consultar ustedes en la página www.cardioinfantil.org. De igual forma, les informamos que esta conferencia está siendo grabada. El chat de preguntas, para que todos lo tengan muy claro, está habilitado en la barra de participantes y realmente les agradecemos que dejen allí todas sus inquietudes y las resolveremos al final de la sesión. Obviamente, le damos un agradecimiento muy especial a Novartis por vincularse como patrocinador exclusivo de esta actividad. Hoy tenemos con ustedes y tenemos el honor de contar con la participación como expositor del doctor Eric Velazquez con la conferencia Role of Neuro-Hormonal Blockade in Patients Presenting with Acute Decompensated Heart Failure. Dr. Velazquez obtained a BA from Williams College. He obtained his medical degree from Albert Einstein College of Medicine and completed internal medicine residency at Duke University. He finalized his training doing clinical and research fellowships in cardiovascular medicine, also at Duke University. Is professor of cardiology at Yale School of Medicine, chief of cardiovascular medicine at Yale School of Medicine and Yale New Haven Hospital, physician-in-chief of the Heart and Vascular Center at Yale New Haven Health. He has been investigator of multiple trials and PI of the trial STITCH and Pioneer Heart Failure. Welcome, Dr. Velazquez. You can start.
Thank you very much, and it's really my honor to be with you today and to speak to you about the management of patients with acute heart failure. My goals today are to really try to touch on some of the epidemiology and how patients present with acute decompensated heart failure, and then use that as a jumping board to update you on some recent trial data that I think has really made a change in our approach to the management of patients hospitalized for heart failure, and go into some of the details underlying some of what we know and what we don't know as well. And then I'd like to spend some time discussing some challenges and how we can address in the future meaningful progress to take care of this population. To just give you a perspective, in this analysis that included 197 countries and nearly 99% of the world's population, you can see that there is a substantial global economic burden of heart failure, which represents approximately $108 billion in total costs annually, of which about 60% of those dollars are in direct costs out of pocket, and 40% roughly representing indirect costs due to loss of productivity and lifespan. So it's a tremendous burden on the world, heart failure. And in the US, and I'm going to focus my comments mostly on what I've learned in the US, there are approximately 1 million hospitalizations for heart failure in the US each year. And that prevalence appears to be increasing for both men and women. And the projected costs are going to skyrocket, with projections that we will be spending over $50 billion in the US alone by 2030. So this is, again, an incredibly important clinical and economic burden that we have to address. So what's been happening? Well, we've had substantial improvements in lifespan and in how we manage chronic cardiovascular conditions as well as acute cardiovascular conditions. But what is interesting about heart failure, since it's the end result of many different contributing factors, is that as the population has been aging, and we as a society of clinicians and professionals caring for patients have learned how to care for acute conditions better, like ST elevation MI and non-ST elevation MI, as well as our risk factor management. What that has led to is actually, in a somewhat unexpected fashion, actually an increase in the population of patients eligible and available and living to develop the later manifestations of chronic coronary artery disease and chronic hypertension, and therefore acute heart failure hospitalizations, in fact, have been increasing. And in the US, the national trends, this is from data that's been published just a little bit ago, earlier this year, suggest that over the last several years, at the end of last decade, that we've actually seen an increase in the number of individuals hospitalized. This data represents 35 of the states in the US, and in the nationwide readmission database of over 8 million primary heart failure hospitalizations. As you can see, there seems to be a rise in the numbers of unique patients and patients discharged with heart failure readmissions as well. So this problem, instead of actually improving, is actually getting more important and obviously requires our attention. Now, in that sample of over 5 million adults hospitalized for heart failure in the US between 2010 and 2017, you can see that while the rates of men are over women in terms of the likelihood of hospitalization visits, for both men and women, the rates are increasing. And when we then evaluate this data and look at it from a different perspective, which is how does heart failure relate as regards to a potentially preventable hospitalization, you can see it is by far the most common hospitalization that is considered potentially avoidable. So you see all these other clinical entities that require hospitalization, such as diabetes, chronic obstructive pulmonary disease, pneumonia, hypertension, asthma, but the most common preventable reason for admission in the US continues to remain heart failure, and that accounts for about 1.12 potentially million preventable inpatient hospital stays, and approximately $11 billion in aggregated hospital costs alone that arguably are preventable. So why is that? Well, the reason is, in fact, that we do a very bad job in actually preventing readmission once patients are initially hospitalized for heart failure. And so you see here in this data set, which is a little old, but the data is, I think, as strong now as before, is that the estimates in the US of a readmission for heart failure is approximately 20% plus after 1 month, nearly 50% at 6 months, and nearly 60% at 1 year. So that arguably at 6 months, we have a 1 in 2 chance of having failed to keep the patient out of the hospital after being diagnosed or admitted with heart failure previously. The other thing that has become evident, and this is a heat map of the United States by different counties, which are the political designations of the United States. You can see that for a condition that biologically should be similar, that there is tremendous heterogeneity in the age-adjusted mortality rates. suggesting that how we treat patients and how we approach to care of patients not only is distinct in different geographic groups, but that the age-adjusted mortality rates are much higher, and again representing to me a real opportunity to improve care across the nation. Now, when we think about a heart failure diagnosis, it's maybe useful to kind of understand when patients present to the hospital with heart failure, who are they? And the reality is about half of the patients who present with heart failure to a hospital are either diagnosed during the hospitalization or have just recently been diagnosed before hospitalization. So, more than 50% of the population was diagnosed when they arrive in the hospital. So their first knowledge of having heart failure is upon being evaluated in the hospital, or they were just recently diagnosed. And therefore, the hospitalization becomes a really great opportunity for us to make a difference in our patients, as well as the impact on our economies and the health of the population in general. So I'm going to spend a fair bit of time going through the evolving evidence on how we approach patients in the hospitalization, not only because it's very common and very costly, but also because it represents a tremendous opportunity for prevention of future events. So the risks and benefits, there are risks and benefits to the hospitalization for heart failure. The patients come in and they're usually somewhat hemodynamically unstable. The hospitalization period is certainly associated with a higher rate of adverse events. Patients have poor outcomes. I haven't shown it, but the rates of mortality during a hospitalization for heart failure is nearly 10-fold higher than the rates of mortality of patients who present with an acute myocardial infarction. So I don't think that's quite well known, but it really represents a very high risk period for patients. These patients also have some challenges based on the adverse event rates, their risk, as well as the instability initially in starting drugs. And so that is a challenge. But the opportunities, I think, far outweigh those risks. There is a real opportunity to reduce early events. I've shared with you evidence of that first months after hospitalization, is a high a period of high risk, not only for rehospitalizations but for mortality. There are opportunities to modify doses of drugs that have been shown to provide a benefit. It also minimizes the need to make substantial reductions in doses if they can be titrated effectively in hospital. Initiating a drug in hospital has been shown to increase the likelihood of adherence and later initiation. So it goes against the unfortunate reality of therapeutic nihilism that we sometimes encounter in ambulatory settings, because patients are sick, they're in front of people, and there is a kind of a golden moment opportunity for patients to be willing to accept new treatments, and for families to be educated about the value of those treatments to support their family members. And as I'll show you, there's a real opportunity to impact what we do in the hospital impacts the potential long-term event rate. So what's the history of acute heart failure therapy over the many decades? And this is a slide that I show very frequently, and it just reinforces the point that in 1974, a very referenced review paper in the New England Journal of Medicine said that to treat acute heart failure, you had available diuretics, vasodilators, oxygen, and there was a need to consider inotropic therapy. So 40 years later, you look at the data that came out of the guidelines in 2007, and you see that nothing had changed. People were using diuretics very frequently. There was a low utilization of inotropes because there's really no very good evidence. Some vasodilator use, and so there really has not been a big change for many, many decades. And in fact, the current treatment through 2019 really represents, a utilization of maximizing diuretics to reduce volume and decongest patients, to use vasodilators if needed, to maximize hemodynamics, intraventricular hemodynamics, as well as to use inotropes sparingly, but sometimes necessarily, to augment contractility when patients are hemodynamically unstable. And there had not been much change, really, in this very long period of time. Now, that's not because there hasn't been attempts to improve things. And I'm just going to show you a few examples of evidence from clinical trials in large numbers of patients that have tried to test whether acute vasodilator therapy initiated early during a hospitalization for heart failure could have a long-term impact on outcomes. These data were developed after a substantial discovery and evaluation process through smaller clinical trials where maybe there were some signals of potential benefit. But when they were tested, and this is an example of ularitide, there was no evidence that a short-term utilization of a vasodilator could lead to a long-term outcome. And I will take responsibility because I've been part of this organization of individuals who've been trying for some time to make an impact in acute heart failure. And I think there was a lot of good rationale. There was good evidence from these drugs and data that would suggest it. But in reality, you use ularitide. We have another example with serelaxin. The results have been really disappointing. And I think unlike decisions that we make in the management of patients who present with acute ST elevation MI, where short-term therapies initiated and continued only in hospital can make an impact on long-term effects. Since heart failure is a progressive neurohormonal disease of sorts, it really, I think, tells me that this focus on acute management without any focus on the long-term management was probably misplaced. And I borrowed this slide from one of my former colleagues, but it just represents a graveyard, a grave marking of that lists all the drugs that have been tested in large-scale, well-done pharmacological trials, testing this concept of an early action, usually intravenously, that have not led to any long-term benefits. And so there's really a graveyard of good, well-intentioned, well-thought-through studies with good preliminary data, but when it's been translated into large populations, has not shown benefits. So where are we? Well, I would encourage everyone to be aware of these two consensus statements, which I think one from the Europeans, one from the American College, that really provide some expert consensus on decision pathways for the management of patients hospitalized with heart failure. And one cartoon from that is the one here that really just kind of reiterates what all of us know who take care of these patients, that there is a little bit of a path that these patients follow, and that the different components of that path are actually opportunities to not only decongest patients effectively, rapidly, while stabilizing hemodynamics, and then to begin quickly to establish what could be effective decongestive strategies in the outpatient setting, while we initiate therapies that are proven in chronic conditions to be effective, and get patients to discharge, hopefully positioning them to avoid the risk that I've shared with you of early rehospitalization. So what are the goals of therapy in acute decompensated heart failure? I would argue that the first and foremost is these patients present congested, and we need to relieve their symptoms and optimize their volume status. I think I'm not going to spend much time on it, but clearly it's important to understand the etiologies. And I would just make a brief comment that it is the data that certainly I've worked on suggests that we tend to not do such a good job at identifying those etiologies and precipitating factors. And in fact, we typically only look for ischemia and coronary disease in about a quarter to a third of the patients who present with a hospitalization, which is really unacceptable since those factors need to be treated in different ways. Then we have an opportunity to optimize what I would say is guideline-directed medical therapy, hopefully in a manner that can minimize future side effects, and an opportunity to educate the patients and their families about why it's so important to utilize those medications and follow up carefully and closely with doctors to prevent rehospitalization and a poor outcome. So what about decongestive strategies? What have we learned? So I'm just going to share with you a few slides from some of the work that my team did as part of the the NHLBI heart failure network. So we had some questions around, believe it or not, we use diuretics every day, but we don't really know how to use them most effectively, because we have never been able previously to test those strategies. So this heart failure network really focused on testing decongestive strategies to try to develop an evidence base for how. One of the questions that we asked was, does it matter how the diuretic is delivered when patients are hospitalized? The questions related about whether we should continue to use what has likely been a standard of bolus infusions versus starting people on continuous infusions of diuretics, and then to test whether it matters the dose of diuretic used if patients are admitted. And the take-home message of that was that it really doesn't seem to matter too much, and bolus infusions, which obviously are cheaper and don't require patients to be attached to the bed necessarily, are probably should remain the standard. And that in patients who are approached with high doses, although not statistically significant, higher doses of diuretics initially appear to have an advantage in terms of the proportion of patients who did better. Then we turned our attention to ask the question whether we should be using ultrafiltration devices that were quite popular many years ago. This data really is 10 years old now. But at one point, and many of you might remember, there was a fair bit of interest in isoosmotic diuresis using ultrafiltration machines at the bedside. And what we were able to show pretty convincingly in my mind was that in this bivariate endpoint of whether patients could continue to lose weight and decongest safely, the ultrafiltration seemed to have an adverse signal with regards to worsening kidney function, with no advantage in terms of volume decongestion. So it really has not this data, I think, really put a stop to what was becoming a very common practice of just connecting people to machines when they were admitted, because there didn't seem to be a benefit. We also looked at the issue of whether we should approach patients with a strategy of what I've termed facilitated diuresis. And so in the RAAS study, we looked at whether the use of low-dose nasiritide or low-dose dopamine with a strategy of consistent diuresis was a higher dose approach, which was 2.5 times the oral doses that patients were on, whether there was an advantage. And the take home was that there was no clarity or clear advantage, but patients maybe who had lower heart failure, a lower reduced EF, might have had, although not statistically significant, maybe derived some advantage in that population, particularly was Nesurotide, but clearly dopamine did not provide any advantage. So I just summarized a lot of data very quickly, but basically coming back to this consensus where we are, is that we really need to use IV diuretics. They are based on dose. We suggest strongly that they should be dosed approximately 2.5 times what the oral standard diuretic was for that patient if they've been previously in heart failure. That we need to be aggressive with regards to our diuresis while we're monitoring symptoms, and make continuous adjustments as needed to that diuretic pathway to decongest people effectively. If people are not decongested, they have worse outcomes and obviously have a higher risk of rehospitalization. So the hospitalization period is an important opportunity to do that well. What we know, though, is that most of the time, diuretics are underdosed in the hospital. And in fact, heart failure patients obviously have somewhat of a resistance to diuresis. And that's really nearly ubiquitous in hospitalized heart failure. And this is data from one of my colleagues here at Yale, which suggests that the diuretic response to furosemide intravenously in patients with heart failure is very, very low compared to the normal diuretic response you would have if that patient wasn't in heart failure. Again, reiterating the fact that diuretic resistance is very, very common, and you need to be aggressive. At Yale, we've actually, and this data was just published, actually have tested this concept of a diuretic pathway. I like to think of this as there's been such an advance in the safety of using antithrombins in patients with acute coronary syndromes, because most of the time those antithrombin are now delivered per protocol by nurses based on managing data that we test regarding prosthrombin times, for example. So it's the same concept. So the clinician orders the diuretic pathway in our electronic medical record. They're asked several questions, and this helps define a starting dose of the diuretic. They're asked to define how much of the decongestion is a goal for the day, and what are the adverse events that need to be plugged in to as parameters. And then the nurse is responsible for making sure those plans are put in place, with the diuretic being titrated as needed every 6 hours based on the predicted sodium output from the equations that have been developed. And this does a couple things. One, it puts some science around the decision about how to dose diuresis. It also provides some manner to manage with real-time feedback on whether it's effective in producing natriuresis, which is what we want from a diuretic. And it also means that the changes that need to be made aren't made only in the mornings when the doctors are moving through the hospital, but can be modified during the day and safely. And that's been tested now and published in this nice paper that was just published about a month ago, where we basically have, in fact, shown that this approach leads to a much more rapid, and you can see here in this part here, much more rapid diuresis compared to the non-pathway days. And we are now working to define how to put this in position for across the system that we at Yale. Another question that's come up is whether we know how to transition people to discharge on what diuretics, and whether it matters which diuretic we're using. In the United States, furosemide is by far the most common diuretic, even though there are alternatives. And approximately 90% of patients use furosemide, while maybe new drugs like torsemide have actually better science to support better pharmacokinetics and dynamics, as well as potentially effects on collagen and aldosterone that might be beneficial long term. When this has been evaluated in a meta-analysis of small trials, and you can see this really includes 43 events in a comparison of torsemide versus furosemide in the torsemide arm and 58 in the furosemide arm. So just, not really sufficient. But when it was looked at, there seems to be evidence to support that there might be an actual mortality advantage to the choice of diuretic one makes at discharge. And so we are in the midst of answering that question using a very pragmatic study that we've designed and is being run in the US called Transform. We've published this rationale and design in the Journal of American College of Cardiology just last month. And what we'll do is randomize hospitalized heart failure patients to torsemide versus furosemide and follow those patients pragmatically, looking for all-cause mortality plus other important secondary endpoints at 12 months. And we've enrolled 2,300 patients already. So we will have this answer in the next 1 or 2 years. If in fact our hypothesis is correct, the impact of just switching people from furosemide, which is the most common utilized, to another generic formulation of a diuretic, torsemide, could have substantial cost savings for the U.S. So we are very happy that the National Institute of Health funded this study because I think it addresses an important and easy to modify aim for the public health. So let me now turn my attention to optimizing guideline-directed medical therapy. What we know is that we do, and I can speak for the US, but I think it's the same everywhere, a really poor job of managing our patients with chronic heart failure using guideline-directed medical therapy. And here you have a slide from an important registry that was led by one of my former trainees and published here. And you can see that only about patients in this registry, all who have indications for these drugs, only 60% of the patients were on an ACE or an ARB. Only nearly 70% of the patients were on a beta blocker, and less than half of them were on a mineralocorticoid receptor antagonist. And actually, if you look at the, I don't have this slide, but if you look at how many patients were on all the drugs at the doses that they should be on, it was less than 1% of the patients. So we have a lot of opportunity to translate the evidence that we have into care. So how does that relate to the in-hospital period? Well, this is data now old, done by some of my colleagues, and I remember when this was done. I wasn't part of it, but it was very, I think, impactful to me. It suggested that in an era when carvedilol and beta blockers were just being put in place, that if carvedilol was started in the hospital, and these were patients randomized to initiation of carvedilol in hospital versus awaiting to starting carvedilol several months later while patients were more stable as ambulatory patients, that there was a substantial reduction in mortality at 90 days. And so the idea was in-hospital initiation of heart failure medications really leads to potentially better, earlier outcomes. So we took this construct and applied it to some of the data that was new coming from the use of sacubitril valsartan. And so we might recall that the Paradigm Heart Failure, really a critically important study, landmark study that established the use of an angiotensin receptor neprilysin inhibitor as a new standard for RAAS inhibitors in heart failure. But it is important to remember that the patients that were randomized in Paradigm were stable and already tolerating ACE and ARB therapy as outpatients. And when they were randomized, there was certainly an important benefit. But there were some limitations to the study because it actually really did not answer a lot of questions related to patients at the highest risk, those patients hospitalized. really there were limited experience with hospitalized acute heart failure patients. Those patients actually were excluded by protocols. They were not randomized. They were the rate of prior hospitalization was quite low, and only 8% of patients had any symptoms of lung RAAS. The diversity of the population was very low. The hospitalization rates were also quite low and not consistent with what we're seeing from the general population. And actually, to enroll into Paradigm, patients had to be on stable doses of high beta blockers and ACE inhibitors for at least 4 weeks, and then to successfully navigate through 2 single-blind periods where they were tested with high doses of both enalapril followed by sacubitril/valsartan, where there was a fair bit of dropout. So this is not to take away anything from the value of the Paradigm heart failure for establishing a new standard, but we had some questions that we wanted to ask. We wanted to know, was it safe to start these medications, this ARNI in hospital? What was the risk? Was there any problems with dose titration and tolerability? And we wanted to test the value of using a low dose in these patients, which had not been tested. And also we want to establish efficacy in the broader population of patients who were either new patients who had never had heart failure, who were admitted and diagnosed for the first time, or were naive to ACE inhibitors and ARBs, who were more likely to be African American, and who couldn't tolerate stable high doses of guideline-directed medical therapy. All these patients were really excluded from or not well represented in Paradigm. So we did this trial called Pioneer, which was mentioned, that really looked at the hospitalized patient with heart failure. We randomized them sacubitril/valsartan versus enalapril, and we looked at different endpoints, with the primary being biomarkers, and only at a short period of time because, as you know, Paradigm had already been presented and had already been established as a new guideline-directed therapy in most of the European and the American guidelines, and so we didn't feel that it could be acceptable ethically to not to keep patients from that for a long period of time. So we used the acute hospitalization period and the first 12 weeks as our period of study. These patients were sick. They had low ejection fractions. They had high rates of natriuretic peptides. And while most of them were requiring still IV diuretics, they had to have no increase in IV diuretics, no symptomatic hypertension, and without the need for any IV vasodilators within the last 6 hours before they were randomized, and no use of IV inotropes within the last 24 hours. So they were a sick population. They actually, as you see here, had was pretty well represented as a population we wanted to look at. A third of the patients had a new diagnosis of heart failure. Over half were not on an ACE or an ARB. The median ejection fraction was very low. The randomization NT-proBNP, which was roughly 6 hours after presentation in the emergency room, was still quite high. The actual emergency room BP and NT-proBNP was about 4,000. So these were very sick patients. And you can see this result's been published. It's been probably discussed, but just to remind you that what we found was a very rapid reduction in favor of sacubitril/valsartan in NT-proBNP that favored at 1 week was significant and continued to diverge over 8 weeks. And what was very helpful to know, and I think reassuring, was that impact on NT-proBNP was not associated with any worsening renal function or hyperkalemia or any symptomatic hypertension or angioedema events. In fact, the angioedema events were more common in the enalapril arm than the sacubitril/valsartan arm. And actually, the permanent discontinuation rates were also more common in enalapril. And we were fortunate, and I think we had planned for this, but we weren't sure if we were powered for it, but it was wonderful to see that this decision to randomize patients to sacubitril/valsartan versus enalapril was associated with a substantial and early reduction in major events of deaths, heart failure, rehospitalization. or LVAD, a 46% relative risk reduction with a number needed to treat 13. Now I'm going to show you here this analysis we published soon after that looked at the paradigm primary endpoint, which was death or rehospitalization for heart failure. And you can see here that in 8 weeks, there was an absolute risk reduction of 5% in terms of reduced hospitalization for heart failure. And this effect in 8 weeks was as large as the entire effect of paradigm over a median of 29 months. So it reinforces the importance of these patients who are much higher risk, and doing something early can have a much more profound effect over a shorter period of time, instead of waiting to patients who are stabilized as chronic heart failure patients. The biomarkers were very supportive, reduced troponin that was significant. Obviously, we talked about the NT-proBNP, and also reduction in biomarkers of remodeling, suggesting there was really a change in risk, not only myocardial necrosis, but remodeling associated with this decision. And it didn't matter. In fact, it was just as significant in patients who were new heart failure patients versus those patients who had been on chronic heart failure and had just had a new hospitalization, as well as patients who were on a RAAS inhibitor before or not. So really no heterogeneity in the effect. Now we did something interesting, and I always give credit to my partner, Gene Braunwald, for his decision, because it was a very smart decision. We decided to have everyone stop study drug at 8 weeks, wash out, and then give everyone, while maintaining the blind, unblinded sacubitril/valsartan. So the patients who had been initially on sacubitril/valsartan continued blinded on open label sacubitril/valsartan, and those patients who had previously been on enalapril were received open label sacubitril/valsartan, and we followed them for another 4 weeks. What we saw here is really instructive. What we saw was that in the enalapril arm who started sacubitril/valsartan, there was a very rapid reduction in NT-proBNP, a quick catch-up. But the group that had been continued on sacubitril/valsartan continued to drop. But what didn't catch up was the opportunity to reduce events. And the fact is, those early events, you can't go backwards. You only have one chance. And so it shows you that the importance of starting early to reduce events. Even though the BNPs can catch up, you don't get a second chance to reduce a mortality event or a hospitalization. And when you think about the economic implications of this work, and this analysis is published now, we believe that if these data were actually utilized in the US, it would actually save 50,000 subsequent hospitalizations for heart failure each year, just by choosing to use sacubitril/valsartan in hospital instead of enalapril. And that would result to a cost savings of about $1 billion a year in hospitalizations alone. And we've looked at this now, published, and really, this is another display of the fact that the lowest risk and the lowest cost, actually, in this case, that sacubitril/valsartan is a cost savings, not just cost effective, but a cost savings approach. So initial early use is cost savings. And when we applied this to registries, we saw that our approach to enrolling in Pioneer was a broadly generalizable one, with about 70% of the population with the guideline registries being effective. Sorry, I changed. So then, now let me just end with a few other points, because I think there's some new data that we have to be aware of. This is data that was published recently in Lancet that suggests the value of starting iron, intravenous iron, for patients who are found to be iron deficient can make a huge impact in patients hospitalized for heart failure. So we should be looking for iron deficiency and potentially treating it in hospital. And also, you see here that this effect reduces hospitalization rates substantially. The other piece, the new data that's coming out, is in the use of SGLT2 inhibitors. This is where we have data from Soloist and a few other studies. What we're learning is that there's a potential really good benefit of the SGLT2 inhibitors on reducing cardiovascular deaths or worsening heart failure, and that benefit is really the highest among those who have been prior hospitalized, and perhaps initiating that also early in hospital might have advantages, but we'll have to await data from even more trials that are coming soon. So anyway, just to conclude, I want to give you some thoughts about how we can improve the data we collect and how we can enhance and move this field forward. The reality is we must better connect the clinical research we do to clinical practice. And what we've learned is that we are good about developing the evidence, and we certainly need to develop better evidence and more evidence. But when we translate that evidence into care, there's really missed opportunities, and the patients suffer. So there's missed opportunities and waste and harm in our system because we don't use the evidence in translating it into care. And we are at Yale really very focused on this right now, and we have been developing real-time live registries. This is just one that was published based on our data for heart failure during the first wave of COVID. So we wanted to ask the question, do we know who our patients are and what are the risks of our heart failure patients based on COVID? So we found that 23% of our heart failure patients had become COVID-19 positive, and 20% had already died. So we just shows you the power of actually following electronic health records live, and whether we can then put in place safety and treatment pathways and testing pathways to make sure that these patients who are at highest risk can be their risk can be reduced. In this case, for COVID, and we looked at how they were treated and are trying to explore the intersection between the treatment decisions in heart failure for COVID and outcomes. We're also doing a fair bit of work on closing the information gap for patients hospitalized for heart failure. And this is one study that is in press that will be published. It's a design of the fastest enrolling heart failure trial that I'm aware of, which is the REVEAL trial, where we looked at whether we can provide, at the time of hospitalization, information on the risk of the patients and whether that information is consistent with what the doctors feel the patient's risk is, and whether they make any decisions that are different based on that risk. And so it'll inform us on how we can educate our care, the care community more. And so it's just enrollment rates have been quite high, and we're looking forward to learning from this experience. So just in summary, very quick kind of journey through acute heart failure management. I hope you agree with me that I've shown you data that suggests that it remains devastating, that its impact financially is global, that the risk spans patients who are de novo diagnoses to worsening of prior known heart failure, that pre-discharge medication initiation is commonly required, and and it could lead to better utilization, and that we need to recognize that when we can start these medications in a hospital, their impact may be long term. We've also just shared with you some data around diuretics and vasodilators that suggest that we still have a lot of work to do on improving our understanding of how they can benefit patients. In terms of PIONEER, I hope I was able to quickly share with you what we've learned so far from the PIONEER heart failure trial. Clearly, sacubitril/valsartan should be used in patients hospitalized with heart failure who are stable before discharge. And it's really, the results were irrespective of prior RAAS inhibitor use or prior diagnosis, and that the economic and other analyses suggest that not only the biomarkers, but also the risk and suggest that this is a myocardial saving as well as cost saving decision to start sacubitril/valsartan in hospital, and that there are new therapies that probably may need to be started as well that we'll be monitoring on the horizon, and that we continue to have to work together to target the implementation of these strategies to improve acute heart failure outcomes, that it's not just about generating evidence, but to put that evidence into practice. And we need to learn how to do that better, and we need to focus in that arena as well. So with that, I'll stop and be glad to take any questions for the last 7 or 10 minutes. Thank you.
Thank you so much, Dr. Velazquez, for your excellent presentation. And now we're going to the questions. I have one to start. I know that in your trial, you had to leave the patient maybe 1 or 2 days after starting sacubitril. But now, do you think it's necessary, or when do you think it's the ideal moment to start it in hospital? The first day or at the last days?
So let me ask that. It's a couple questions here, so let me answer one. First of all, you're right. We required all patients to have at least a 36-hour washout period. And that's because we had a blinded study and we didn't know if we wanted to enroll patients who were both on prior ACE inhibitor use as well as not on prior ACE inhibitor use or RAAS. And we wanted to keep it blinded, so everyone got 36 hours. But if patients are not on a RAAS inhibitor, they can initiate sacubitril/valsartan right away. There's no need to have a washout, but still the washout is recommended and is part of the labeling for patients who are on prior RAAS inhibition with an ACE inhibitor or an ARB, just to minimize the potential risk of angioedema. And so that it was a trial-related decision, but I think in clinical practice, if patients are not on prior ACE or ARB and have not been on it for the last 24 hours, you can initiate the drug right away. If they've been previously on it, they need to have at least a 36-hour window before you can initiate the drug. And in my opinion, the data that I've seen suggests that the earlier you can initiate it, the better. The Pioneer data, but is of course limited by how we conducted the study. So please be aware that we used some clinical perspectives to define the inclusion criteria. So patients had to be not requiring increasing IV diuretic doses, so they were actually decongesting effectively, that they were not hemodynamically unstable from the perspective of their blood pressure, so they had to have a blood pressure of at least 100 millimeters of mercury for the last 6 hours, and they weren't requiring inotropes. So those are the very minimal but basic hemodynamic guidance that we provide, and I think assuming that those patients those inclusion criteria are met, I think it's better to start earlier than later.
Thank you. And before I pass the next question for Dr. Maria Juliana, a quick question. In your diuretic pathway, you do the sodium output every 6 hours?
Yes.
Okay, thank you. Maria Juliana?
Okay, we have another question here. Being aware of the results of the acute decompensated heart failure trials, do you think the conclusion would be that early initiation of modifying therapy before discharge, it is the only clue in acute heart failure?
Yes, if I understand the question correctly, I think that that the hospitalization period is a tremendous opportunity to start these drugs, and that the evidence that we have from beta blockade as well as from now Pioneer suggests that we should start those drugs in hospital if we can. And even the other thing that I didn't talk about with my presentation, but we tested a low dose of the drug of sacubitril/valsartan, and that was effective, and it was based on blood pressure. And so I think using a blood pressure target to initiate these drugs allows you to start the drugs safely, and then you can titrate them based on whether blood pressure recovers as an outpatient. My experience personally, as well as from the evidence from our trials, suggests that in fact, actually, patients tend to have recovery of blood pressure faster in the patients who are on sacubitril/valsartan, probably because they're doing better. And so you have even though you may not be able to tolerate a high dose in hospital, you may be able to continue to up-titrate it in the weeks and months ahead, which is what we did in the trial.
And probably the titration trial told us the same. I mean, it was
Yes.
as a okay. And we have another question here. How comfortable you are with down titration the loop diuretics in the first 2 weeks after discharge the patient in order to rapidly titrate the ARNIS and add probably an SGLT2 inhibitor?
It's a great question. I think we all want maybe a little bit more data, but I think my personal approach is to do exactly what that was suggested by the question, which is to once patients are adequately decongested, to reduce diuretics quicker, so to allow utilization of drugs that are shown to have a benefit in terms of morbidity and mortality. As you may see, I was not able to show you, nor does anyone have any evidence to suggest that diuretics actually lead to a difference in morbidity and mortality. It's very hard to test that because obviously we have to decongest patients, but the other drugs do, and so I use diuretics only when needed. So if you don't need it, I use the blood pressure for the other drugs.
Okay.
There's another one that's, what is your experience in the use of ARNIS in patients with renal failure stages 4 and 5? There are some case reports with heart failure with reduced ejection fraction.
Yeah, so those patients were clearly not evaluated in the clinical trials. So the big ones like Pioneer and Paradigm. I think there is, in my own personal experience, not based on any guidelines or regulatory data, I have done that and monitored very, very carefully for hyperkalemia and worsening renal failure, because sometimes, and those of you I'm sure are aware in your own practice, sometimes you actually see an improvement in kidney function when you are helping to offload the myocardium, and so sometimes you actually can get patients' kidney function better, if you carefully monitor it. But it should be done very, very cautiously and carefully, and certainly be monitored like for electrolytes and other things. But the data from the big clinical trials, obviously we didn't test it. We don't know.
We have here another question. What's your approach to etiology in patients labeled as non-ischemic cardiomyopathy after a normal SPECT? Do you cut them or continue therapy based on their nuclear stress test?
It's a good question, and I would say there is certainly some controversy in this a little bit in my answer, but my practice is that everyone should have an evaluation of their coronary anatomy who has reduced ejection fraction at some point. And so while there may be clinical conditions that would allow an evaluation by SPECT to be sufficient, it would certainly be more ideal to get to rule out major coronary blockages. As you know, there are some conditions associated with reduced ejection fraction where SPECT perfusion might show a balanced result, but might actually hide severe left main and RCA disease. So I tend to be more aggressive in terms of making sure that at least everyone has had an evaluation of their coronary anatomy. The other thing that I would say is that in this day and age, at least in the U.S., we are learning to become even more confident with our utilization of CTA for those patients, and so I don't think it needs invasive angiography every time, but I do think we do need an anatomic evaluation of their coronary arteries.
Thank you. I don't have any more questions.
I have another question here in another chat. Someone is asking us, is pioneer heart failure the end of an era for levosimendan?
For what?
For what? Levosimendan?
Levosimendan. So, you know, it's interesting. In the US, levosimendan was never approved. So I have no personal experience with the utilization of levosimendan. Levosimendan was not approved by the FDA, so we have never used it for acute heart failure in the US. So from our perspective, it's not the end of the era because the era never started.
All right. It was a good answer.
Yeah.
I don't have any other question here, Dr. Monica. Do you have another one?
No, I don't think so.
Well, thank you very much for the opportunity to talk to all of you. I hope this was helpful.
Thank you very much.
My pleasure. Bye-bye, everyone.
Bye.
Gracias a todos por acompañarnos. Estaremos en nuevos eventos